So good morning still, and thanks for joining us over what typically would be your lunch hour. Really excited to have a really interesting panel and discussion today talking about social determinants of health. My name is Jim Conway. I'm from the other UW, University of Wisconsin. In our School of Medicine, I'm the Director of Global Health Programs there. And I just wanted to reflect briefly, and I'll keep it short, that it's obviously great to be back in person, but it's also great that we've been able to sort of harmonize and synergize organizations, and that as CUGH has re-entered into an in-person, having the Academic Health Centers International under AAHCI also here, as well as the World Health Summit, has been really, really exciting to bring together organizations that have very similar and like-minded approaches. I'm a pediatric infectious disease specialist. I've been fortunate to be at a lot of universities that are here and seeing the evolution as I went from Cornell to Northwestern to Colorado to Indiana and then to University of Wisconsin, and seeing so many of these great schools that have really made global health a priority. And it's interesting because I was at some of the very first GHEC. I don't know, does anybody remember GHEC? The old Global Health Education Consortium. It's been really sort of an interesting thing to see the university programs parallel the evolution of these organizations, because, we all started out as sort of educational organizations, and, as my dad, who was the head of the Department of Education at University of Buffalo, used to quote George Bernard Shaw, those who can do and those who can't teach. And it's been really interesting to see that turned around, that we went from being teachers and educators to being increasingly involved with stakeholders to being more and more responsive, and then coming back to this whole idea of investment in communities has been really, really a wonderful progress. And seeing CUGH really embrace that, I think has been really great. When we think about the social determinants of health for the students in the room, I think for those of us that started out doing global health for many years, it was doing what we thought was the right thing to do, and finally realizing we needed to be much more engaged with the communities and stakeholders to be taught what it was we needed to be doing. The social determinants of health have been a framework to help us think about that. And you can sort of put them together in categories, and we're going to see some really interesting talks that sort of address that over the next 7 hours. So when you think about economic stability, education access and quality, healthcare access and quality, neighborhoods and built environments, and social and community engagement, those really sort of are the umbrellas of social determinants that are really important. So with that, I think we're going to get started so we can hopefully catch up on time here. You'll notice that the speakers are a little bit different than what's in your program, and also in a different order than what I had for the introduction, so we'll see if I can get these right. I'm also going to cut these down a lot because otherwise you'd spend the next hour listening to introductions. So the first speaker I've got the pleasure of introducing is Andy Falak, who's the Senior Interim Vice President for Health Affairs and Dean at the College of Medicine at University of Cincinnati. He previously was Senior Associate Dean for Academic Affairs, founding Chair of the Department of Medical Education. He's a Professor of Medical Education and Family and Community Medicine at University of Cincinnati. He also served as Vice President for Education. Most importantly, from his 7-paragraph bio, he received his medical degree from George Washington University, School of Medicine and Health Sciences here in Washington. So without further ado, Andy, I'm going to let you take over.
Well, thanks, Jim, and I'm from that other WGW for that. So thank you all. It's a pleasure to be here. I was going to be saying good morning, but it's now, I think, good afternoon. We're a little late getting started, so it really is a pleasure to be here. And as indicated in the program, addressing health disparities and inequity in healthcare is a global challenge. And certainly in the United States, our healthcare system is not working as well as we would like it to be, or as well as it should be. We clearly spend a lot on healthcare and less on the social factors that contribute to health. And as noted by the World Health Organization, it is estimated that social determinants of health account for between 30 and 55% of health outcomes. So what I hope to do in the next few minutes is to provide a context to simulate some discussion. I'm going to briefly define and describe social determinants of health to make sure we're all on the same page, present a brief case study, describe an educational module, and describe a global health initiative. And as Jim said, we only have 7 hours for this, so I'll cut it short. To start off, I want to offer the context and the definition I suspect many of you, if not all of you, are familiar with, and Jim alluded to the 5 areas and categories that are on the slide, and this is the definition that's used by the Department of Health and Human Services for Healthy People 2023. But I'm going to read to you a slightly more expansive definition that I like, which is the World Health Organization statement. Recognizes that the social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. And this just lists, what Jim had alluded to, some of the specific examples of some of the social determinants of health. So I'll give you a brief case study. I'm a family physician, and I'm in my office, and it's a busy morning, and I'm already behind by 2 or 3 patients. My medical assistant knocks on my door and says, your patient that was scheduled at 9:30, and it's now 11 o'clock, just showed up for appointment. And by the way, the patient seems to be in moderate respiratory distress and is wheezing. So she goes, what do you want to do? My first impulse is, well, maybe we can send the patient to the emergency room or the urgent care center. But instead we take care of the patient, we step out, and we do everything that's needed to take care of this patient. And the patient gets their breathing treatments, does well, clears the wheezing, and we send the patient home. And boy, that's a success. We stabilize the patient, we send him home, right? Doing well, patting ourselves on the back, and we saved an ER visit, all in the same time. So we take that in our current medical system as a big success. So the medical treatment is fine, but what are some of the factors that come into play in caring for this individual? So when we look at that is, why was the patient late for the appointment? Was it transportation an issue? Could they not get the time off from work because they were afraid of losing their job? What precipitated this asthma exacerbation? Did the patient stop taking medications? Was it because of the cost of the medications? Or was there a health literacy issue in that they didn't know how to use the inhaler appropriately? And if it's cost, how's the patient going to get the medications you just prescribed for them to prevent another visit to do that? What's the patient's housing situation? Is the patient homeless? Are there smokers in the home? Are there allergens? Did the patient live in an industrial area with heavy smog and pollutants? So those are the questions that are raised. Or can an individual physician with a busy schedule be expected to address all these concerns? And what are the incentives to do so? And we focus a lot on trying to solve a problem at that level, and that isn't going to work. So I offer this just to give that perspective. We have a system that, at least some of the time, and for some people, provides good medical care for an individual. I know how to treat illnesses and diseases quite well from the medical perspective, but it's only part of what my patients need. And how do we work to provide better care overall? And when we look at this, our medical education model, whoops, we lost the slides. There we go. The medication model tends to follow the healthcare delivery model. We also need to understand that no matter what we teach the students in the classroom, they'll model what goes on in the world of clinical practice. We teach medicine the way it currently is being practiced. Actually, a lot of time we teach it the way it used to be practiced. And we need to really work to teach how medicine can and should be practiced. So I'm going to describe just briefly an educational program that we have for our medical students in Cincinnati, and I know there are lots of great ideas that are going on in the country. And as I frequently state, we do a very good job of teaching medicine, but we don't always do a great job of teaching how to practice medicine. So one solution is to get the students out of the classroom and into the communities in which they live and work and play and worship and learn. So starting in our first year, we have a course called Physician and Society, and one component is a service learning module. For this course and for other activities, our students are assigned to learning communities. This allows them to start function as a team, and in this service learning module, each learning community is paired with a community health agency to investigate the determinants of health. The intent is to provide the students with an opportunity to partner with the community and learn from them, and to foster concepts of citizenship and social change. No matter their future specialty, students build the skills and identity as a community responsive physician. The culmination of this is that they have to do a project. Here I've just listed what some of the objectives are, but the overall intent is to help break down biases and barriers that might exist to help the students better understand various aspects of their local community and to help them examine their own personal beliefs and practices. The projects are done with the community partners, and these are just a few examples of the diversity of the kinds of projects that they do, from putting together an educational video to helping an agency do a survey of what the needs are to help them assess the needs in their community. And all this is available. You can go to the University of Cincinnati College of Medicine website, and this course has a lot of that information on there, and you can really get a better sense of what that's going on. And again, the key here is to engage the students with their communities to help foster the changes that are needed to provide equitable care for all. And I'm going to close by describing a program that was established by one of our faculty members, Chris Lewis, MD, Village Life Outreach Project. A reality is that our colleagues who have been working on global health projects have been leading the way in addressing social determinants of health. The concept that VLOP adheres to is maintaining an intense focus on working with communities in partnership rather than serving communities. It's working with them. And as Chris explains, when he first went to rural Tanzania as a resident as part of a global health rotation, he became really sensed a need and wanted to do something. And early on, VLOP focused very narrowly on health care. But in working with community leadership, he learned that much of the health conditions that they were working on were coming from a lack of clean water. Through this, a partnership was done with the College of Engineering to work on water access and clean water. And this goes back to some of the concepts in the case study. We can treat the illness, or if we understand the whole context, we can more significantly affect change for the community. So Chris worked with community leaders and partnered with them to address their needs. In this one community, they knew there was a need for clean water. He partnered with UC's chapter of Engineers Without Borders and led to a development of a well and distribution system that now provides safe drinking water for more than 7,000 people and has prevented thousands of cases of waterborne illnesses such as diarrheal illness and schistosomiasis, among others. A clinical brigade going 2 or 3 times a year cannot have that same kind of effect. Another community I know they wanted me to go quickly, but that was a little bit quicker than I had hoped to do, so sorry about that. Another community felt that education was the most important issue. So a school was rebuilt, again partnering with Engineers Without Borders, and it leveraged the community. It provided jobs for the local people to build this school. And they realized then that the kids came to school, but nutrition was a big problem. So he then partnered with the College of Allied Health Sciences, Department of Nutrition Sciences, and they developed a porridge that the students get. So the students now come to school, they get this high caloric porridge every day as part of that, which enhances their learning. And there are other outshoots from that. So one of the other outshoots is the kids would go there, and that's the equivalent of an elementary school, but the high school is 3 hours walk away, a pretty significant barrier. So what he implemented then was a bicycle program where people can donate money or can donate bicycles. It cuts that commute down to an hour a day, and more students are able to go to high school. So it's working with the community and addressing those needs. That was just the nutrition part. Then the last one is in the third community, they actually did build a health center. This is now permanently staffed by locals and provides full labor and delivery services so that mothers know there's a safe place to give birth. And it also serves as a center for immunizations. So in addition to the 14,000 or so people that have been seen by the brigades over the years that VLOP has been, there's now sustainable development that is enhancing the health and well-being of the community. Yes, there's still a lot to be done, and addressing the social needs goes beyond what the healthcare system can provide. We all have a part. We can do certain things at the point of care. We need to continue to educate our students beyond the medical model, and we need to continue to work with our communities, to partner with them, to assist them, to listen to them, and empower them if we are to meet our goal of improving the health of our community. We need to do this locally, and we need to do this internationally. In closing, I just want to thank all of you for the great work that everyone in this room is doing on a daily basis to affect positively the health care of our community. Thank you very much. Now I think I can go to that thank you slide.
Thanks, Andy. That was terrific and a great example of the local to global, back to local, and around and around. Next up, I'm really pleased to be able to introduce Argavan Salas, an MD PhD who's a national leader in diversity, inclusion, and equity, and has a PhD from studying at Stanford. Just strike that from the record. And I fear her because she's actually a surgeon as well. She's got an extensive lived experience as a woman of color living in a male-dominated environment. Apologies. And is really a remarkable and really successful individual with a wealth of experience in both the public forums with media, but also in her publications. She went to medical school and residency in general surgery at Stanford prior to completing a fellowship in minimally invasive surgery at Washington University, not the one here, the one in St. Louis. And it's my pleasure to have her join us up here. Thank you very much.
So I'm really bad at tracking time, so I'm going to buzz myself here with a timer. Otherwise, we could go on all day. I was thinking 10 hours, not 7, so I'll adjust down. Thank you so much for the opportunity to be here. And this is an amazing crowd. I didn't know coming here how many people would be at this session, so thank you all for coming. Before I get into the content of my talk, one, I'm going to do disclosures, and then I want to make a comment on the title of the session before I get into my content. So I do some work with Intuitive Foundation and Intuitive Surgical. This is a robotic company, does not have anything to do with the content I'm presenting today. I also work with a diversity and inclusion consulting firm called Exponential Talent, and they don't pay me, but I just like to be transparent. I always also add some positionality statements to my talks. So I am a surgeon, as was mentioned. How many surgeons are in this audience? We got a few? Hooray! I happen to identify as a cis woman. I'm also an immigrant from Iran. This is a global health meeting, so I'll just take a moment and acknowledge that for 7 months now, the people in my country have been fighting for freedom, and they've been led by women and girls, and I'm very hopeful. Yeah. Thank you so much for that. That's very powerful. I'm hopeful that we will see meaningful change and that Iran will join the global community in the way that it was in the 70s and before that. The other thing I'll just say is that I stand in front of you as someone with lighter skin, so I don't identify as white, but I do have the privilege of having lighter skin tone, and I recognize that, I take all of these identities with me to everything that I do, including giving talks like this, and so that's why I mention it, because we cannot divorce ourselves from these identities that we carry. You all are great. I just may stay for 10 hours. And the thing, before I get into to this slide, I do want to say the title of the session is Social Determinants of Health. And I can't take credit for this, but I saw it, I think on Twitter a couple years back, this question of, are they social determinants or are they structural determinants? Because a lot of the things that have been mentioned, like, yes, go ahead, yeah, I'll take it, I love it. But a lot of the things that have been mentioned, like, are differential access to education, differential access to healthcare, differential access to money, are structural, especially, I can speak very clearly to the United States, that these are things that are built inherent in the ways that this country was founded. And so they are structural. I would just consider or encourage folks to consider that when you're thinking about these issues. Okay, so on to what we're going to talk about. I'm going to jump right into a very specific healthcare-related disparity, which is the maternal health. So first of all, we know that the United States has atrocious maternal health compared to similar countries. Even worse maternal health, though, for Black women. Black women are 3 to 4 times more likely to die due to pregnancy-related causes than are white women. And there's some other comments here on the right side of the slide about the leading causes of these deaths, hypertension, obesity, diabetes, or contributions, I should say, to these deaths. But one thing to keep in mind that's really important and gets lost a lot of times in these conversations is that even when we take into account things like education and socioeconomic status, Black women are still more likely to die in this country from pregnancy-related causes than are white women. So this is not simply an issue of not having enough education or not having enough money or not understanding. Because the issue is, hopefully this is already all in your heads or in all your heads, the issue is racism, right? It's not that these women are showing up in a different way. It's that our system is racist. The structures, the systems, and the individuals are racist. And if there's I don't know if there's a better example than this one to get that point across, because Serena Williams, obviously powerful woman, the greatest of all time. I'm just gonna say that. You can disagree, but I'm just gonna say it. And even she, with all the power that she has, the wealth that she has, the knowledge and the education that she has, and the privilege that comes with that, had a severe complication after she delivered her child. And complications can happen. I'm not blaming any health system on the fact that she had a blood clot, but what she describes very clearly when she talks about this and when she writes about this is that people did not listen to her. She had previously had a pulmonary embolism, so she knew what that felt like, and she said, hey, I think I have another PE. I think we need to get an ultrasound or we need to do a CT scan, and they did not believe her, and they kept telling her she was going to be fine, which led to a delay in her diagnosis, which eventually was that she had a PE. So if even Serena Williams has to fight to be heard, what are the chances for other women in our system? I'm trying to click. Okay. This is an article, again, highlighting this point. This came out in the New York Times based on a research article. This came out a few weeks ago, and you may have seen it, showing that rich Black parents birthing people, their infants are about as likely to die as the newborns of poor white birthing people. And that is really wild if you think about it. Especially since, again, a lot of times people will say, well, it's because they didn't have, for example, access to healthcare. You know, the richest Black women do have access to healthcare. It's not an issue of not having access to healthcare. It's, again, all these other structural determinants that we've been talking about. Interestingly, so I do a lot of work on the workforce, so that's more my kind of focus in DEI work. And so I want to make this link between these disparities that we see, and obviously there are many more racial disparities, and I'm only talking about anti-Black racism today, but obviously there's lots more that we could be talking about. But whenever we talk about these, then we can look at the data of how does that relate to what's happening in our workforce. And so there's a really powerful study that came out a few years ago looking at newborn mortality and looking at the race of those newborns and the race of the physicians caring for them. And what they found was that for white newborns, it didn't really matter. They had equally good outcomes with white physicians and Black physicians caring for them. But Black newborns were almost twice as likely to die if they were cared for by a white physician compared to a black physician. And this mirrors other data that we have as well that shows that essentially when we have racial concordance, the outcomes are better. And despite that, this is what our workforce in the United States looks like for the physician workforce. So 56% white. The next biggest category is Asian at 17%. 5% of our workforce is black physicians. And actually, if you look at the highest level in academics, at the full professor level, 2% of full professors in this country are black, despite the fact that black people are 13% or so of the population. And this is especially concerning. So that's concerning in and of itself, right? But it's especially concerning when you think about the concordance data on health outcomes. And I don't say that, the clicker is like 1 for 3, I think, just so you know. It's like scoring an F right now, but would do well in baseball. I'm really trying. Oh, there we go. So I say this not to say that even if we had 13%, say, physicians in this country being black, that all black patients should be cared for by black physicians and no one else is responsible for caring for those patients. That's not at all what I'm trying to say. But I do think that we need to get to that point of equity anyway. And then perhaps the rest of us can learn from these black physicians how to better care for black patients, while of course addressing the structural issues that exist as well. I'm going to share just 3 slides quickly on what's happening in our medical schools in terms of race and admissions, because I think a lot of times people have this perception or this idea that with time things will get better. There will be an inexorable march toward progress. And I'm just going to say right now that is not true. That is false. And I'm going to show some data as to why I make that statement. So this is from the New England Journal last year, looking at 3 different years, 1980, the year 2000, and 2019, and looking at enrollment in our medical schools in this country compared to the representation of these various groups in the US Census in those years. So the middle lines in these 2 parts of the graph are the US Census population representation of these groups in those years. So bars extending to the left are underrepresented groups compared to their representation in the population. And first of all, you see that many groups are underrepresented. But the more important thing that I want to point out is if you look at women, which is the top part, Hispanic women are about as equally represented now as they were in 1980. American Indian and Native Hawaiian Pacific Islander women are less represented now than they were in the past. Even more concerningly is what's happening with our men students. Black men are less represented now than they ever have been in the past. Same with American Indian and Native Hawaiian and Pacific Islander men. So again, we're not just gonna, by waiting, see the changes that we want to see. We have to take intentional action across our medical schools, across our hospitals, etc. I have just 2 more slides, and we're not gonna spend a lot of time on these ones, but to give you kind of a backed out, zoomed out view of what's been happening. So on the left here, you see from 1970s to about 2015, the racial identity of medical school applicants. And you see, white students, it's kind of gone up and down. Asians are really the only group that's had like a significant increase over time. And the 2 lines at the bottom, or 3 lines at the bottom, are Native American, Hispanic or Latino, and then Black and African American students, where we see really not much change at all over time. And if you look over to the right and look at the rates of acceptance by the race of the students, pretty obvious that there's a problem here in our admissions process, and that Black students are much less likely to get accepted than those from other races and ethnicities. And to that point, the next slide, if it ever comes up, will show that the number of Black medical students who are admitted every year is about the same, regardless of how many Black students are applying. So it's not an issue, often people say it's a pipeline issue. It's not that we don't have Black students applying. It doesn't matter how many Black students apply. We still only admit the same number, by and large. Now, these data are a few years old because this is from an AMC report that hasn't been updated yet, to my knowledge. Do you think it matters if I dance? Or okay. So This is, I think, the last kind of data slide that I wanted to share, and I'm doing okay on time so far. These inequities in our admissions processes also continue on into careers beyond that point. And I'm going to share just a few different studies on a few different aspects of our professional lives in academics. The first one actually could be, it doesn't have to be in academics, but it's about who gets interviewed. And this, many of you have probably heard some of these studies before, where people send the exact same CV out in response to job ads, and all they do is change the name at the top. So it's the same set of experiences, the same exact education, and then they see who gets called for an interview, or in some iterations of this, they just ask, how likely would you be to hire this person? What do you think this person's career potential is, et cetera. So there was a study that did this using 4 different names. So same CV, 4 different names. And the names were either Emily or Greg, which were the white names, and then Lakeisha and Jamal, which were what they called ethnic names. And what they found was Lakeisha and Jamal were much less likely to get hired or be thought of as hireable than Emily or Greg, again, for the same exact CV. So when we assess the quality of work of a person, there was another study, by the way, that looked at, my therapist thinks I have ADHD, I do a little jumping. I swear it's related. So there was a study that looked at a paragraph or an essay that they sent out, and they asked people to critique it. It was professors. And if they thought it was a black student, they found many more mistakes in the writing than if they thought it was a white student. So the point is that when we evaluate work and we think it's done by someone who's black, we think it's not as good. And that we is everybody. Another issue, so once you get past that, right, you get interviewed, you get your faculty job, whatever, then you're going to work on your career. If you're at an academic center, you may be applying for grant funding. And the NIH, I think, has done a really good job of looking at their data and pointing out that they have a real problem in the way that they review grants. Grants that are proposed by black researchers are much less likely to even get discussed. If they don't get discussed, they're obviously not going to get funded, but they don't even get discussed. And when they've looked into trying to understand why this is happening, one of their hypotheses is that black researchers are more likely than other groups of researchers, and specifically than white researchers, to propose human subjects research, to try to understand some of the things we've been talking about, these structural determinants of health and what's happening in our communities, and the NIH has not valued that work. And so to their credit, they are trying to work on this, but clearly it's not been solved. And then, of course, those biases that come into play when we're evaluating applicants from their CVs also come into play when we're talking about evaluating grant proposals. And data from the AAMC has shown really significant barriers to mobility, upward mobility through the ranks for underrepresented in medicine folks. That's my timer. And again, 2% of our full professors are black, and 2% of our full professors identify as Hispanic in this country. So I want to leave you with this, which I said at the beginning, and I'm just going to say again, all of this is happening because of racism. That doesn't mean everyone in this room is a bad person. It just means that we have structural issues, we have systemic issues, we have institutional issues, and we have individual racism on top of all of those. And so we need interventions at all of these levels if we're going to provide the outcomes that we want our patients to have. Okay, last slide I'll go through real quickly. This is for anybody. You don't have to be a leader. These are things that you can do to make a difference, at least in terms of the career pathways and the support that we're giving to our trainees and our junior faculty colleagues. So one is to amplify the work of and the voices of the people who are not heard. This happens all the time in rooms, physical or virtual, where certain groups' ideas and their voices are muted or discounted. And we all can say, hey, I'd really like to hear, I'm going to go back to that slide, we'd really like to hear what Jamal was saying. I want to hear more about that idea. We all can do that. You don't have to have clout to redirect in a meeting. Giving credit to people, we are in a very competitive atmosphere where everyone's trying to prove themselves, but I truly believe that lifting other people up is the way that we all will get ahead. And so we have to work on that in ourselves, all of us, to make sure that we are acknowledging the work that other people are doing and building with them, not on top of them. And then not making any assumptions about other people's interests or their priorities. For example, just because someone in your organization is black does not mean that they want to do work in DEI. They may want to work on hypertension, or they might want to work in a lab doing bench research. So this assumption that anyone who is part of a marginalized group wants to do DEI work is false, and it takes away from the career opportunities that those individuals might want to pursue otherwise. There are a lot of places you can donate, especially if you're interested in supporting Black maternal health or community health. There are many resources out there that you can look at. We published a piece last year in JAMA with some specific places that you could donate to that we think are credible. But if you have money that you want to give, that is one thing you can do. And then sponsoring people, sorry, I'm now like probably 3 minutes over, almost done. So sponsoring is really important. Mentoring is talking to people about what they should do, and sponsoring is talking about people in spaces where they are not. So that's giving them an opportunity to co-author a piece when you get invited, giving them an opportunity to speak when you get an invitation to speak. It's nominating them for committees, nominating them for awards, etc. And then the last one here is to not gaslight. I know that probably most people aren't intentionally gaslighting, but we often jump to, well, are you sure they meant it that way? Or, maybe this one is actually probably intentional. Maybe you're being a little sensitive. When people tell you what they're experiencing, believe them. Believe them. And then, I swear, I think this is the last slide. We probably don't need it. I think it's just my contact info. Oh, here, equality and equity. This difference is huge. You all probably know it if you're sitting in this room, but this is my favorite graphic. People use the baseball fence thing. I really like this one. It's from the Robert Wood Johnson Foundation, and the idea is equality, which a lot of people in academic medicine think is giving everybody the same thing, giving everybody the same bike, regardless of their size or their ability, to me is very unfair, whereas the bottom panel, which is equity, is giving people what it is that they need. So it's recognizing, oh, you're shorter, you may need a smaller bike. You're taller, you may need a bigger bike. Maybe you're not able to sit up, right? You need a recumbent bike. And so this is the challenge to all of us in our organizations, is to help people, give them the tools that they need to be able to move forward and be successful, rather than saying, sorry, this is what we have. We have this bike, good luck to you, I hope you can ride it. So let's shift from that mindset to understanding that we need to meet people where they are, and that really is it. There. Thank you for your time.
And now you can see why I was so excited that she was going to be part of our panel. Really terrific, and obviously a lot to think about. Moving on, Philip Alberti has the unenviable position of actually following that show. As the founding director of the AAHCI Center for Health Justice and senior director for the Health Equity Research and Policy at the Association of American Medical Colleges, Philip Sparks supports and contributes to community-driven multi-sector efforts that build evidence for programs, policies, practices, and partnerships that eliminate health inequities. And I'll tell you, having been here most of the week with AAHCI, the Association of Academic Health Centers International, and AAMC, this is a clear and present focus for the organizations and a major part of the discussions throughout the week. As was just highlighted, AAMC is probably one of the best sources of data to help us really make meaningful change around these kinds of things. Prior to joining AAMC, Philip was part of the New York Department of Health and Mental Hygiene and actually worked to promote health equity in New York City neighborhoods. So again, a really great example of local and global. So Philip, you're up.
Thank you.
And apparently you need to hit the clicker like a minute before you want
yeah.
to.
I wish I didn't have so many animations in my slides, but there we go. And it's a perfect setup. Thank you, Dr. Salas, for that. So you'll notice kind of provocatively that social determinants isn't in my slide title. We're going to talk about social needs, vital conditions, and fundamental causes today. But at the, where's the best place to point it? There is not a good place to point it. There we go. So here's kind of our mantra in the Center for Health Justice. We say health equity is our goal, and health justice is the path or the framework that gets us there. So before kind of diving into some actual concrete actions, I'm going to unpack each of these sentences just for a little bit. So health equity. There we go. So we all know this slide and this definition. Health equity is a state where everyone has a fair and just opportunity to attain their highest level of health. That's a great definition. It's a little vague. It's not really tangible. So I'm going to ask us all, if the animation works, It would have been so funny. We'll put a pin in it. There we go. We're going to put a pin in this definition and come back to it to try to make it a little more real. Like, what actually are the conditions on the ground that would indicate that we've achieved this state of just opportunity for health? So we're going to go here first. So I like definitions. I'm an epidemiologist by training. And so many of our institutions say, oh, we screen all of our patients for social determinants of health. Not so much. You're really screening your patients for health-related social needs. We're going to carry this example forward. So the social need of your individual patient might be, I don't have stable housing, right? The social determinant, and I don't love social determinant for all the reasons that were just presented. I also don't think they're really determinant. So I put this in brackets, right? What we actually mean by social determinant largely is my community lacks affordable housing, and therefore I, a patient or a person, have an individual social need of I don't have stable housing. I want to introduce a new framework that's been kind of gaining adoption, particularly in HHS here in the United States, and that's the Vital Conditions for Health framework. So the vital condition, go back, bummer. We'll just leave it here. Okay. The vital condition in this scenario is humane housing, right? We're not just interested in our communities having housing. We're interested in our communities, every community, having humane housing. And so here's this incredible vital conditions framework. This paper just from a couple of months ago. On the left-hand side of the wheel are these vital conditions for health. These are the asset-based, the positive, the goals that we want in all of our communities. We don't just want transportation. We want reliable transportation. We don't just want any work. We want meaningful work. Right? And then on the right-hand side, you see these kind of immediate urgent needs, right? Yes, we absolutely have to provide urgent medical care. We absolutely have to provide in real time to crime and environmental impacts, et cetera. But what we're really focused on are creating opportunity for health by every community having these vital conditions. So where does medical care locate itself on this wheel? I think it's really important that we right-size our roles and responsibilities and understand via this oddly drawn pentagon. Sorry, I'm not good with PowerPoint like that. But this is really where kind of, we always hear, well, what's medical care's, what's healthcare's lane? What lane are we going to stay in? And at some point, I'll make a better slide because I think we need to get out of our lane and kind of carpool and jump in the HOV lane and like work on this together. So slide coming next time. I didn't mean to do that. Anyway, that oddly shaped pentagon kind of made it clear, if I could get back to it, but I'm not going to try, that you have, right? Healthcare really owns that acute care for illness, of course. On the social determinant or the vital condition side, you own a sliver of basic needs for health and safety, right? That sector, that trivial pursuit piece of the pie includes potable water and fresh air and fertile soil and, yes, access to high-quality medical care. So I said put a pin in that definition of health equity because I wanted to translate it into something a little more practical and meaningful, and what the actual goal is. And for us in the Center for Health Justice, we say that health equity, right, that just opportunity for health, is realized when every community has and provides the basic vital conditions we all need to thrive. I want to spend just a second or two, maybe a minute or two, on this sentence and kind of parse it a little bit, right? Every community. We have some really harmful narratives to undo in our health equity work, right? So health equity isn't like Robin Hood social justice, where we're going to steal health from community A and give it to community B, right? Health equity literally benefits every single community. Part of I'll own this, part of my problem, our problem in the health equity space is we are excellent at screaming our truth to each other. We are less excellent, right, at bringing more people, right, widening our audience, broadening the tent, making it clear that the goal of this work is that every single community at every intersection of identity, right, has access. And I don't just mean kind of the default theatrical access where someone might say, well, we built you a supermarket, it's 7 hours away, there's no public transportation, and you don't have sidewalks, but it's your fault you didn't access it. That's not what we're talking about either. We're talking about kind of default access, right? Just by being in place, you have access, real opportunity for meaningful work and reliable transportation and all your needs for basic health and safety. And the last thing that I want to point out here is that word community. I think it's really important, particularly, and another huge threat as a public health person and a population health guy, is the medicalization of health equity, right? These issues, health inequities, health injustice only exist at the population or community level. And that really is important for the kinds of interventions that are going to be most effective at creating that just opportunity, at providing those basic vital conditions that everyone in this room and all the communities from which we hail need to thrive. So let's see. So the last kind of social factor I want to talk about, so we have social needs, vital conditions. I also want to talk about fundamental causes, which is a core part of my training and I think really resonates so well with the last presentation, right? So in this case, to carry it forward, the vital condition might be classism and racism, right? Operationalized through specific policies, zoning policies, building practices, et cetera, that again, maldistribute across our communities those vital conditions and then result in the individual patient or person's health-related social needs that you might screen for and encounter in your clinical settings. So that's the health equity side. Now, what kind of interventions are going to be impactful? This is a little gross self-promotion. This paper's coming out next week for some authors from the center. This is our population health impact pyramid for healthcare. And so I'm going to start at the base of the pyramid. First, though, I want to note, interventions at all 7 levels are crucial. This is based on Dr. Tom Frieden's 2010 Public Health Impact Pyramid. This is not to say that we only want to focus on those bottom 3 tiers. Absolutely not. Each and every tier is necessary, but insufficient if we're truly going to create those vital conditions in our communities. But my training was all about social factors like racism, classism, homophobia, transphobia, fill in your isms and phobias as fundamental causes of disease. What does that mean? Definitionally, that means those social forces impact many, many outcomes, not just health outcomes, education outcomes, you can add the list, right? They operate through many, many different pathways. So you can block off one pathway, and that fundamental cause is clever because it can find 20 other pathways to exert its downstream influence. It really requires an aligned, coordinated effort, right? And the other thing is fundamental causes control access to health-promoting resources, not just money, but information, power, right? Who's at the table, beneficial social connections. Right? We don't need to look very far in our country, in the United States in 2023, to see how those fundamental causes, racism, classism, transphobia, are today, right now, working their ways into our political determinants of health, as my good friend and colleague Daniel Dawes would say, right? To intentionally, in some cases, maldistribute those vital conditions across our communities, which then demand that we take action, that medical care and other sectors in that collaborative take action to change our context, make different kinds of long-lasting organizational commitments, and then all the way up to the way in which we educate future leaders and future practitioners, no matter what sector we're coming from. So I want to just focus on those 3 levels today, though, very briefly. So we talked about health-related social needs, vital conditions for health. There is an animation. Let's see if I can. There we go, 3 stars. And then fundamental causes of, in this case, the absence of classism, sexism, racism as fundamental causes of health and wellness. So just some examples of what our member institutions are doing across these 3 levels. So socio-medical interventions. For example, many, many institutions, I think the 2019 paper was like 87% of healthcare organizations were screening and referring for health-related social needs, referring to community partners. I always want to stress that diagnosis, right, and actually encourage all of you to formally diagnose health-related social needs via ICD-10 codes as an important data source for changing the healthcare context in terms of what gets reimbursed and what doesn't get reimbursed, right, et cetera. We are seeing via 1115 Medicaid waivers the reimbursement for more community-based practitioners that are better positioned, frankly, no offense please, than physicians to create those trusting bridges with communities, promotoras, doulas, community health workers, et cetera. Another really exciting socio-medical intervention that's really taken off in the last 10 or 15 years are medical legal partnerships, right? Formally incorporating a lawyer on the care team to address health-harming legal needs, right? If you have an asthmatic child whose asthma is exacerbated and you're in the ED once or twice a month, but they have their inhaled corticosteroid and the real problem is mold and pests that your slumlord is not addressing, not too much a care team can do, but there's a heck of a lot that a lawyer can do. And so that care model is another really important example of how we can broaden the care team and think about those socio-medical interventions. Yes, we're still kind of one patient at a time, but in the case of medical legal partnerships, the data and the anecdotes that are gathered en masse create opportunity for movements to change local policy, state policy, federal policy, based on the kinds of health-harming legal needs that are showing up in our EDs and our clinics. Vital conditions, again, kind of the humane housing, meaningful work, reliable transportation, many institutions are truly trying to walk that anchor mission talk. You know, many healthcare orgs say, well, we are anchor missions. We're large, we employ a lot of people. Okay, fair. But really the spirit of anchor work is community economic development. Right? What can your relatively well-financed healthcare organization do in terms of prioritizing local procurement, local hiring, making actual investments in local businesses, again, to spark community economic development. We all know if you are a not-for-profit healthcare organization, you have to think about community benefit policies. Flip that form over, that Schedule H form. There's a whole list of community building activities that are also incentivized. Things like multi-sector partnerships and economic development activities like we just talked about, and coalition building, right? Multi-sector partnerships and alliances are a huge part of what it takes, again, to jump in that car together, carpool in the HOV lane. And then something that I would be remiss not to mention is that voter registration, civic engagement, for not-for-profit institutions is A-OK. It is a nonpartisan way to engage people in the process. And importantly, it's the center of that vital condition model is civic muscle and belonging. And so our institutions, your institutions, can also easily get involved in that. Fundamental causes, this is just to say there is a lot of evidence from my mentors, Bruce Link and Joe Phelan, not just in the theory of how those social factors influence population health, but then tests of the model over time. And so for us in the center, the way to really address those fundamental causes, those isms and the phobias, is through, and there's a lot of animation coming up, through a health justice agenda. And the way that we talk about health justice at the AAHCI is to say we keep one foot in, let's do it. Here we go, it's coming. Nope. Okay, 1 foot in community wisdom and multi-sector partnerships. That's it. That's where we start, right? The first question is, what is the lived experience that we need to understand and build all of our work around? We are not the experts. That's the process foot. I love process. The second foot, that worked really well that time, is a research to policy action imperative. We heard earlier today, and this is about implementation science, right? It's about evaluation science, program evaluation, centered with community wisdom, that then those solutions can be embedded into policy change at all levels, organizational, local, state, and federal. And that we use both of those feet, in my case kind of to strut, I would say, towards health justice in a very explicitly, I'm never gonna have animations again, anti-racist and anti-discriminatory way, being very intentional about whose voice is at the table, who has power in decision-making, right? How is that work being done? What is that process? So I'll just say one or two quick things. They'd be quicker. Oh, we'll go back. Oh, that was, nope, oh, it's going the wrong way now. This is a test. Here we go. I want to say about community engagement very quickly. What I don't mean by community engagement is kind of all of you with all of your expertise going to your community advisory board on a quarterly basis and saying, hey, community advisory board, I have a bunch of really great ideas. What do you think of my really great ideas? Can I get a thumbs up? Yes, check the box, community engaged. That is not what we're talking about. You all know this work, whether it's global health, domestic health equity work, requires all of those descriptors in that green circle: co-equal, shared governance, equitably financed, and the one that I've highlighted, trust. And I won't get into the process, but one of the first things the center did was try to flip the script and say, this isn't about communities getting over their mistrust and distrust. This is about institutions and organizations with power and privilege demonstrating they are worthy of community trust. And so we worked with folks from about 7 different geographies across the US to develop our principles of trustworthiness. I'm not gonna go through these. There's a whole toolkit and action guide wrapped around these, but I'll give you like 3 of my favorites. 1, the community is already educated. That's why it doesn't trust you, right? There we go, yes. Right? Have some respect. Take some responsibility for your not only historical, right, abuses, but contemporaneous abuses. Number 2, you are not the only experts. That is not so easy for public health and scientists and physicians to hear, right? But it's true, right? Lived experience, on-the-ground experience is as valuable, if not more valuable, than the clinical, scientific, public health skills you bring to the table. And then my personal favorite, number 7, there is more than one gay bar, one bodega, and one black church in your community, right? If you are only engaging the same people over and over and over again, you are missing huge segments of the folks that are crucial for your work to take root and flourish. And so the purpose of all this, that process, but you already saw the slide, is the process is as important as the product. And in fact, only by doing the work in this way will the outputs that you are hoping for come to life in that real way. I'm going to zip through the action foot. So there's this great generation framework of health equity science. The first generation is descriptive epi, which populations, how big are these gaps? Second generation analytic epi, why do they exist? What maintains them? Philip Alberti is done with first and second generation science. We have to switch to that third generation of solutions. And again, evaluation science, implementation science, community partnered scholarship that takes that local wisdom, builds solutions, and again, we implement that into policies at all levels. And the main message from that action foot is that medicine, you all have outsized voices at every advocacy table, right? They don't want to hear from me. They want to hear from you. And so it is possible, in fact, it's an important imperative that we raise those voices in service of advocating for health, for those vital conditions, and not just medical care, because it is that kind of collaboration. So all ways to keep in touch. Sign up. I didn't talk at all about what the center's actually doing, but I'm happy to talk after. You can email me and get in touch this way. Thank you so much for the time and the privilege of being here.
Wow, really terrific and great segue from taking these things into much more actionable items as we think about this and challenge ourselves. Last but not least, batting cleanup. Elaine Adams is an associate professor and global health director at the Department of Family Medicine at beautiful McGill University. From 2010 to 2016, she was in Dhaka, Bangladesh with a number of joint appointments, including the director of the Center for Urban Equity and Health. She's a recipient of a Commonwealth Scholarship, completed her PhD in public health at the London School of Tropical Hygiene and Tropical Medicine, and a postdoc at Harvard University. So join me in welcoming Elaine.
So can you see me? So talk about equity. Podiums are my problem. So that's why I wear platform sneakers. Happy to wrap up and be the last wheel. And I apologize. When I say social, I mean structural as well. So very, very important sort of clarification I think we heard from Argavan. So let's try this out. Okay, it was very fast. So just first to say that our concern for social and structural determinants of health isn't new. In fact, it's been kind of waxing and waning over centuries. In England, the sanitary movement of the late 1800s sought to improve the health of the ailing working class through investments in better housing and work conditions well before the advent of modern medicine and antibiotics. The Declaration of Alma-Ata in 78, followed by the Ottawa Charter, lots of references to Canada here. I'm Canadian at McGill. In 86, reaffirmed the importance of intersectoral action for primary health care and for health promotion. And then we had WHO's 2008 Commission on the Social Determinants of Health, and that called for improved living and work conditions and importantly, actions to counter the inequitable distribution of power, money, and resources as necessary actions for health equity. So more recently, our collective experience of the COVID-19 pandemic, fueled by the George Floyd murder and the discovery of unmarked graves in Canada's residential schools, put social determinants of health top of mind, highlighting their neocolonial underpinnings, their complex intersections, and inequitable impacts. So it's not surprising that we're seeing social determinants of health increasingly embedded into health professional training, and that's what I'm going to be speaking about today. So as Sharma et al. Note, too often social determinants of health are presented as facts to be known rather than as conditions to be challenged and changed. So underlying our educational efforts is a tacit assumption that instruction about the social determinants of health will produce health professionals that take action to improve health equity. Shockingly absent is instruction about how to lead or be allies of change. And here I would suggest, rather than minor curricular modifications, we need major institutional and instructional transformation within health professional training to produce equity-oriented agents of change. On institutional transformation, we need to disrupt the status quo by reconceptualizing standards and structures to increase diversity so that future health professionals reflect and respond to the diverse needs and characteristics of the populations they serve. And this means doing things now. Now it's happened. Okay. All right. Shall I try again? Okay, so this means broadening admissions criteria to consider other dimensions of excellence, not just GPA and MCATs. It means increasing financial accessibility to educational opportunity. And I think about this country in particular as one that doesn't do that very well. Ensuring mentorship and support to diverse student bodies, and then also attracting creative educators ready to lead. So in terms of instructional transformation, we'd do well to reconsider the 2010 recommendations of the Lancet Commission on Health Professional Training for the 21st Century. And what's really interesting about this report is they say it's not about informative learning is important. We need to produce experts. Formative learning is also important. We need to create professionals. But very importantly is transformative learning. In other words, integrating transformative learning into curriculum, thereby nurturing the necessary skill sets and attitudes to tackle systems that sustain inequities in health. So I'm going to offer two examples of educational initiatives that I've been involved in over the last few decades that have embraced transformational learning with the goal of producing critically conscious, equity-oriented, and socially engaged future health professionals. And the first is in Dhaka, Bangladesh. It was the Brack School of Population or Public Health was bold and unprecedented in its design, and it's an ambition to create an innovative public leaders and solutions through cutting-edge experiential education, training, research, and advocacy. So to date, it's trained almost 600 students across all the continents, many students from Africa and all over Asia, to learn and think and do differently. Students interact with community and service providers from day one of the program. They're asked to observe, listen, engage, and be curious, and to put their comfort aside and to make equity their ambition. Among their first experiences is to wander the alleyways of a sprawling informal settlement, along with community health workers making their rounds. Groups are assigned to social determinants of health, education, water and sanitation, gender, food security, etc., and they're asked to explore their scope and their impact on people's lives through observation and informal conversation with community members. Overwhelming complexities are revealed through this process that force students to interrogate their assumptions and critically assess the design and approach of public health interventions. And many have gone on, and some are here, to lead change in their own countries. A second example is from the global north, and that will come up in a moment. McGill in particular. And it's the design of a new undergraduate program in population global health that we're very proud of. And this program seeks to nurture globally minded change agents through the development of 6 key competencies that embrace the social and structural determinants of health, but also include skill sets needed to challenge and change the status quo. These include capacities for systems thinking, problem solving, critical reasoning, and knowledge translation and communication, while at the same time creating opportunities for cognitive disequilibrium. In other words, students encounter unfamiliar ideas, they cast a critical gaze on their own values and experiences and the structures around them. This is realized through 8 required courses and a choice of 5 interdisciplinary thematic streams. So a foundations course sets the tone with a strong emphasis, and this is Canada, on Indigenous health and the social and structural determinants and the vital importance of global solidarity around planetary health. This is followed by a course on equity and ethics in which students interrogate their assumptions through real-world case studies, role play, and empathy mapping. A community-engaged learning course has teams of students working on projects prioritized by community organizations with an emphasis on listening and learning, collaboration, and reflection. And then a full semester experiential learning placement at the end of their training encourages the development of professional capacities critical to leading change, including humility and teamwork. So here are a couple of examples from the global north and south on how we can nurture this next and critical generation of socially engaged and globally minded health professionals. And for those of you who are educators, as am I, we too have to work on being better allies and equitable partners in actions that address the social and structural terms of health and health inequities. We have to give up our power, we have to embrace complexity, we have to work across sectors, importantly, and encourage our students to do the same. Thank you very much.
Grab a seat.
Oh, okay. I want to get my pen. There.
You can have your pen back. I'm going to ask the rest of the panelists to come up and join us here on stage. We're a little short on time, so we're going to ask for questions but not speeches. And if you're going to go to the mic, it's a valuable period of time, so it better be good.
All right.
There should be microphones. Yeah. Please.
Yes, thank you. My name is Ijeoma Nodimopara, representing Wayne State University School of Medicine in Detroit, Michigan, and Nigeria. Whoop whoop. And I have a speech. So, just kidding, just kidding.
Well played.
Just kidding. Thank you. Excellent, outstanding presentations. And really, to take it from my brother from AMC, fellow AMC, charge and Center of Health Justice member, absolutely, period, point blank, without justice, equity, and asking the question, how did we get here, at the center of our research, at the center of our education, at the center of our processes and practice, we are only replicating and perpetuating the same power imbalances and agents of these processes, whether we realize it or not, period, point blank. So that's my speech done. Now, question. I'm reminded back in 2008 when CUGH Executive Committee released the definition of global health, quote unquote, by Copeland et al. I don't know if Copeland is here, but and it's this beautiful long paragraph on global public health is the field of study and ... Y'all can Google. And that's what was published, right? Now, at that same meeting, there was a Kenyan doctor who pretty much defined public global health as, global health is the field of study, or basically what the Euro-American regions call what the rest of us just call health, right? So I can't help but think, as someone who does work in structural systemic determinants of health and these fundamental causes before they were named all these glorious things for many, many, many years, and my work is grounded in the work of Black and Afro-diasporan grassroots justice work folks who have been talking about the same things for centuries, right? That is social determinants of health, simply what indigenous Afro, American, Asian, indigenous communities just call health, right? This acknowledgement that health is integrated. It's the body isn't separate from the mind, isn't separate from the spirit, and the person is not separate from family, from community, and community is not separate from society. And this is how this has been the way our epistemologies have always been organized. And in 2023, we have glorious PowerPoint about, and show this brilliant, and again, I'm an academic and researcher. I'm talking about myself too, because I'm trained by y'all. Anyway, and so, and we talk about this, but folks on the ground have been practicing this as part of resistance work to the oppressive work of colonialism that's still ongoing, racism and the other fundamental causes. And so my question is, what is missing? What is missing in all that has been presented, and why and how we will leave and still continue what we've been doing for years? What is missing and what needs to be centered in CGH and beyond, and all the represented organizations and on individual and institutional level? What is missing and has been missing for why we're here and why we don't ask and answer that question, and how it will be different once we leave out of this conference on Sunday?
There's 2 microphones.
All right, I'll say something. So thank you for the thing that popped into my mind. You know, I mentioned the harmful narrative of like the zero-sum game, right? And so I think the speech and the question really gets to the core of another harmful narrative that's particularly salient, not just in the United States, but in kind of Western cultures around the world, around individualism, right, versus the collective. And I think, I don't know how a conference or a definition can change that, but it's part of that same problem of speaking to each other and the folks that get it, and not being able to broaden the tent, because we do have this strong vein of meritocracy, harmful narrative, right? What's a meritocracy when the starting line isn't equal, right? Individualism, when the collective, as you said, is embodied in so many other knowledges and ways of being and epistemologies. And I think I don't have the answer, but I think you've really identified some core barriers to really pushing this work forward in a way that, yeah, I agree, is part and parcel of so many other places and peoples and times. And yet we are struggling and redefining, kind of talking around and chomping around the edges, because we have these sets of important core beliefs in our culture that stand in the way, I would say, of equity and justice.
Yeah, I agree with all of that, and I would say that those are maybe not just beliefs, but myths on which our society is based. And I would add to that list capitalism and what
White
people
supremacy?
Yeah, exactly. Like all these intersecting systems of oppression, and we can all have in our hearts whatever we want to have in our hearts, but at the end of the day, we go back to a place that pays our bills, and that place is integral to the function of capitalism in our society. I don't know how to change that. Maybe you and I can do it together. I don't know. I don't know. Open to any suggestions and willing to be part of that work, because it's hurting all of us in so many different ways.
You know, I think as the moderator, I get to talk whenever I want. It's almost like being at that microphone, but one of the things I think that you actually just presented was really important, which was the silence. And I think we get into the thoughts of the known knowns, the known unknowns, and what you're challenging people is to help figure out what are the unknown unknowns. And so that's the challenge to everybody in this room and at this conference, is to start asking those hard questions that you're asking. Is what is it we don't know that we need to know about to finally not have to have these kind of meetings over and over again. So thank you for that very much. Next one.
Ben Canny from the University of Adelaide. Really enjoyed the session. Thank you. I want to ask a question about admissions/selection for health professions education. So putting diversity issues to one side, and thank you so much for bringing that up, because I think it's absolutely critically important. To create those transformational agents which are going to bring about the changes to social structural things, do you think that's an education problem or a selection problem? And if the latter, how do we go about it?
Sure. I can talk to that. If I understood the question, it's whether selection or education are what lead to the inequities related to the, no, sorry. Okay, so are we like selecting for the wrong people and that's why we're not getting transformational change? I actually think, I mean, yes, I think we do have a problem with selection. That's, part of the argument I was making because of the ways we evaluate work and how much we buy into the myth of meritocracy and what it means to like have what it takes to get into medical school or whatever. Those are very flawed definitions in many cases, built on a specific type of person who has access to a lot of privilege. And people who don't have access to that privilege aren't seen as good candidates in many cases. So I do think we have a selection problem. But I also think whoever you take and you put into the system changes them into this product that comes out. And the product that we're making is not necessarily a bad product. I mean, I'm one of the products, but it's not creating that force for change in people. In fact, I think we're indoctrinating people into how to keep things exactly the same.
Elaine, do you want to?
Well, yeah, I guess I also think we're sort of failing on the educational front. I mean, the selection issue is very, very real. But on the educational front, I think we're too embedded in old models. And I think we need to listen, more to that next generation. And they're asking for engaged learning. They're asking for learning that makes a difference. They're wanting something very different from the university than what we've been sort of doling out for centuries. And so it behooves us to begin to really reflect and innovate, and I would say, importantly, create those critically conscious, agents of change that I mentioned before. How we do that has to be quite different than sitting in a lecture hall, and we have to rethink how we educate. Yeah.
Earlier this week, we heard some discussion of universities getting out of the university and into younger and younger age groups and actually starting to mentor and nurture people from these communities that actually are then going to be the people that we want in the universities. But universities have to get out of their own silo at some level as well. Yeah, one.
You couldn't have teed up my question better. So hi, I'm Eric Choi Pena from Northwell Health. Thank you all. The presentations have been fantastic, and even the community or our community participation has been fantastic and a great discussion. My question is, so how do we get out of these silos? CUGH is a silo in and of itself. Global health community is a silo. Public health is a silo. I've been spending a lot of time, I'm looking for funding for my center, so I've been spending a lot of time outside of our silos, and the outside world really doesn't get it. Like, they're talking about AI like it's gonna solve the world, and it's just gonna reproduce all the biases. We've seen it. It reproduces biases in the resumes that you just mentioned. It's reproducing those biases because it's learning from our biases. And so how do we engage these other sectors that believe in capitalism and meritocracy and show them that this is inherently also bad for capitalism? It's bad for, unhealthy people is bad for our planet. And how do we engage a larger discussion that engages the people outside of our camp? Because I'm pretty sure you've sold 104% of this room. But how do we sell the people that didn't come to this room that are in our society and get them kind of in our camp? So thank you.
Well, I'll start with, I think, the pat answer, you have to start somewhere. You have to take baby steps, and you have to start doing that. So now there's how many more people here who can go out and have a shared common message. We struggle sometimes over definitions and things like that, and we get people confused. And the more clear we can be with the common themes that we're working on, the better we're going to be able to move this forward. The work that Philip and his team are doing is absolutely phenomenal. You need to pay attention to that, use a common language to move things forward. And we all do it together. And one of the examples I gave, it was one individual who started those major changes in rural Tanzania. So we all can start somewhere and do things, or we can sit and be academic and sit around and talk about it and study it forever. So I think it's time to get out there and start doing things.
I agree. And the only thing that I would add is I think so much of engagement from our institutions, well, I'll say two things. So one, our internal houses also have thousands of silos of excellence when it comes to this work, right? So I think part of it is what are the organizational competencies around coordinating, aligning, understanding who in your public health school, your medical school, your hospital, your healthcare system is already doing this work, are already engaged. How do we make that seamless, right? And that's one thing. I think also our incentives aren't aligned for relationship building for the sake of building relationships, right? We're great around engagement for an R01, we're great for service learning opportunities, right? But whose task is it to build and sustain relationships just because we want partners and partnerships that can be activated not when there is a public health emergency like a pandemic. That's too late, right? But that can be activated because we've been building and maintaining and strengthening those conversations, speaking with one voice, not trying to push an agenda, but trying to explain how the collective, right, this partnership will benefit all of us. So when we need it, we can use it and work with it together.
I'll just add a very quick note, which is somebody mentioned this earlier, and I forget who, but I think one of the arguments to people who aren't fully on board yet is a really important one, which is that all of this work improves everything for everyone. If we make conditions in healthcare better and more accessible for, I talked about Black people today, specifically Black maternal health. We improve Black maternal health, we are going to improve white maternal health as well. And so it's not, and I think you said this as well, you might both have said this, it's not about like taking anything away from anyone, and to your point as well, the scarcity mindset that we currently hold is really damaging. So trying to shift that into an abundance mindset, and then just helping people understand that it's not about taking anything away from them if they're in positions of privilege, but it's about making things better for everyone. Like if you think about, I'll just give one quick example, parental leave, right? If we have parental leave for everybody, not based on their gender or their chromosomes or whether they birthed or didn't birth, that's better for everyone, because who does not want to be at home with their baby? I mean, that's a problem. I mean, I'm just gonna say it's problematic. If you'd rather be at work than with your baby, something is going on. Anyway, that's my 2 cents.
As a pediatrician, I'll say on behalf of the babies, yes. One of the other things that you all kind of touched on, and I want to give all of the speakers a lot of credit, I think one of the things that we all have suffered from as we've tried to make this clearer to our other colleagues is using clear, tangible, concrete examples that actually drive it home, and to get away from jargon and use terms that people, like box 7 is going to be in my head forever. Seriously, because like that's the type of stuff that helps people that aren't here get it. And I think that we need to be less jargony and more clear and use clear examples. I think we got we'll just keep going until we haul me off.
Quentin Eichbaum, Vanderbilt University. So I've been with CUGH for 10 years and served on numerous committees and the board. And the debate of decolonization has taken hold quite strongly at CUGH, and it certainly impacts what you're talking about in local communities as well. But one way in which we need to break down these silos, and also served on the AAMC's Frame Commission for the integration of the humanities in medical education, we need to bring the humanities more intimately into global health, and that's my mission, and I've been talking about this for a long time. The solutions to decolonization and many of the things you've talked about cannot be solved by epidemiologists and infectious disease experts. We need people from history, we need people from anthropology, we need linguists, we need people who deconstruct these concepts much better for us. So I started the Global Health Humanities Working Group at CUGH, and Ijeoma and some others have served on this, and I would just want to encourage people to participate in this. These are vital people who contribute to the debate. So I'm curious in your work, to what extent, there is a question, not just a speech, to what extent have you engaged historians, and you can't talk about decolonization without historians in the debate, or anthropologists, or linguists, or sociologists, in breaking down and better understanding some of the issues you've been speaking about.
I agree fully with you, and I think if I look at what our faculty looks like now in the College of Medicine than when it did, say, when I was in medical school, the world has changed quite a bit. We're embracing more. We have a long way to go in those areas, but I think we need to talk about the silos with the medical school in departments, to break those down. Well, When I talked, today we talked about the partnership with engineering, with the other colleges at the university. At a university, we have all those resources available, but we don't know one another to do that. We can rely on all those and really make progress if we do that. We need to, it's breaking down the silos, embracing people and welcoming them in, that it'll raise everybody's boat with it.
Wayne?
Well, just to say that this new population global health program that we've put together is actually, housed in the Faculty of Arts, and very intentionally, because we really want to, build those bridges across the different departments in the arts faculty and bring their perspectives to bear on some of the issues that we are addressing together, but from different disciplinary perspectives. So one of the things that we have brought into the curriculum is this idea of streams, where students choose a number of themes, or one theme really, and then identify courses in different disciplines that kind of address that theme. So we begin to develop in students an appreciation for these different and important disciplinary perspectives. They may not be experts, but at least they have an appreciation of how much value there is in bringing those to bear on the complex issues of the day.
For those of you that were at the World Health Summit yesterday, first ever hip-hop opening was pretty spectacular, and I think was a great example of how messaging and how communications need to be meeting people where they are. And I was shocked and thrilled that we've actually started to bring even that kind of humanities things into the actions that we're all taking here. Last two, and then we'll get people to lunch.
So I will keep it short. Hannon Kerr, I'm a clinical cardiologist. I'm also on faculty at University of Cincinnati College of Medicine. So my question is about health professional education. And so I really appreciated all the comments that were made. And I think the medical schools are doing an outstanding job. I think that there's a huge change over the last 10 years in putting the social determinants of health into the curriculum. And I've been involved in some of the courses that Dr. Filak has mentioned, where you incorporate all that information and you work with the M1s, the first-year medical students, for a year, and they're involved in the community, and something happens when they become in the fourth year and you're in the clinical setting now and you're looking at patients and you're rounding and you're doing all that and you're asking them, well, does the patient have support at home? What is their living condition? And that is lost. And I think that we have a lot of restrictions and constraints and pressures as providers to get to the bottom line and treat that asthmatic patient and just get it done and finish it. And so there has to be, I'm interested, the question is, how do we make that transformation from the infrastructure? And for the institutions that are under a lot of pressure themselves, they have a lot of pressure to have RVUs and to have productivity and money matters and all that stuff. And how do you make those two worlds connect? Because they're totally disconnected, right? So we want to care, we want to ask, we want to do all those things, but our systems are not promoting us to do that, and they're not rewarding us to do that, and almost disincentivizing us to do that.
Yeah, so I'll just take a stab and say that our incentives are completely messed up in every possible way. If you look at, there was just an article that came out showing, I think it was 100,000 nurses are leaving the workforce due to burnout related to the pandemic. Why? Because we haven't changed anything. We saw over 1 million people die in this country alone, and we said, okay, we'll just go right back to exactly what we were doing that led to everyone being sick in the first place. And by that, I don't mean sick in terms of the pandemic, but I mean just our system was sick before the pandemic, and we're like rushing to get back to it. And to your point, it's incentivizing RVUs instead of incentivizing care, and incentivizing procedures instead of time spent understanding the situation of our patients. And that's a systemic issue that I really think we need to burn it down, truly. Like I'm on that radical side of things. Like I don't know how we fix this system and keep like the bare bones of the house. I don't know. I can't wrap my mind around it because it's so messed up. And for our medical students, it's so clear that I 100% agree with you. They're coming in with a very different set of expectations, as you said as well, compared to even when I was in training. And they are right, but they come into the third year and they get indoctrinated into the explicit and the implicit curriculum of what it is to be in healthcare. And we know the data, right? They become more depressed by the end of medical school. They have less empathy by the end of medical school. And that's because of what we're doing. And so until we change our incentives so that they're aligned such that our time with patients is valued, and we as human beings, by the way, are valued, because right now we're not as physicians. I don't know how this is my take, I don't know, because those are fundamental problems.
I don't think things are going to get better unless that's addressed, honestly.
Yeah, well, and then the other thing, sorry, real quick. So to the point about nurses, travel nurses are way more expensive to hire than making conditions at your hospital better so that the nurses will stay, right? But what are many of our hospitals doing now? They're just bringing in more and more travel nurses because it's too hard, right, to make a change.
I was just going to say, we can learn a lot from our neighbors. We're not neighbors, but I guess to the south. Chile is completely reforming their healthcare system. It's going to become a care system, which I think is really interesting. They're fundamentally changing the way they think about well-being and health and well-being. And so it's a ministry of care, which I think is absolutely amazing, and I look forward to seeing how that rolls out. But I would say one of the things I'm working on right now, I'm a social scientist, and I'm working on this idea of social prescription, because it is the case that busy health professionals can't do it all, even though they do understand fundamentally that they're sending often their patient back to the circumstances that produced the health problem in the first place. So this idea of bringing into the system connectors who can help assess patients' social needs and then link them up with services within the community, and there are a lot of them. So building those systems out more formally, I think, is really a way forward, particularly given the situation we have right now in terms of the health workforce being so absolutely overextended and burnt out. So let's create the supports for them so that they can ensure that their patients get their non-medical needs addressed as well.
So I had the privilege of practicing in a rural community for 4 years. And in that community, and it was decades ago, people took care of one another. People helped one another. People knew one another, and the support systems were there in a way that I just don't see now in the same way, unfortunately, to do that. And those were, some of the better times in my practice of medicine where it was much more enjoyable like that. They knew where they can go and where they can turn and do things. And you can get help and do things like that. So.
As an example of, we're a little bit too US-centric sometimes, and I would argue that, I don't know how many countries are in the UN anymore, but there's 192 grand experiments going on at any given time around the world with different health systems, and I think there is a lot to be learned from a lot of those health systems. You go into places like Thailand where prevention is prioritized and their cost of healthcare is $600 a year compared to $12,000 in the United States, and they have exactly the same life expectancy because all of their money goes into prevention. So I do think that this is a forum where maybe there needs to be a half day of let's look at all the different health systems and look and see what you can pick and choose from everybody's successes. Everybody's got failures and challenges, but I agree with you. I mean, I'd rather not burn it down, but I certainly am happy to take it down to the studs and then start rebuilding from there. All right, last word, and then we can get lunch.
Well, thank you for the great discussion. My name's Holly Campbell-Rose, and I'm from the National Institute of Mental Health at NIH. And I just wanted to add to the siloing comment and, well, all of what you said. The Lancet published some papers about 2 weeks ago on economic and commercial determinants. And for those who are not aware, it's blown the determinants level up to large corporations and how they impact our health. So I just wondered if you were given the opportunity to build a team that could tackle that, or maybe even one of your other not so grand issues, what type of person would you put in that team?
This will be great. I want one comment from each of you.
I'll be very quick. So one of the first things that we did when we ideated our Center for Health Justice back in 2019 was to say we definitely want an advisory body, but we want an advisory body that looks like no other advisory body at the AAHCI. And what that meant for us was, 1, they're going to get paid. 2, physicians will only have one seat at that table. So we have a group called the Multi-Sector Partner Group. They are local experts, state-level experts, national experts, in fields as diverse as the arts, as public health, education, civil rights. There is a physician there. And in addition to kind of working with our collaborative that we work with to kind of tap that community wisdom, we make sure that all of our work is resonant across sectors so that the outcomes we're evaluating, the perspectives we're getting, kind of incorporates from the very beginning perspectives beyond kind of traditional public health and healthcare. So that was kind of our intentional approach to institutionalize that as part of our process.
Who's going to be on your team?
Just quickly, I think it's getting people who currently are not at the table involved, that we rely on the same people all the time, and I think that, slide number 7, box number 7, really resonates. It's welcoming in people who have different thoughts, different concepts, and different ideas, and that isn't something that in medicine we do all that well.
Well, just to add, I think people have lived experience. People who are, living these issues, on a daily basis. They're really important voices to be heard, but we have to make those spaces ones which are comfortable for them, and it's not necessarily a big stakeholder table, policy table. It's going to be that place to hear those voices. So I think we have to change up our model of listening and go to communities and listen there.
Maybe add engineers or physicists and think even more broadly.
Yeah, absolutely, yeah.
I think no one maybe said this point. I agree with everything that's been said, but I really value social scientists. And my PhD, I studied social psychology, so I'm like partially one, myself. But I really value that perspective because they haven't been indoctrinated into the work of academic medicine, so they can see things more clearly than a lot of us who are in it, especially those of us who've been in it longer, can. And so I think that's critical to having any sort of really critical examination of what we're doing and coming up with innovative ideas for how to do it differently. The other thing I wanted to say to your question is about our care is so fragmented in our system. And I think also if we don't address that, we're not going to be successful with whatever change we make. Because right now, if a patient comes to me as a surgeon and I don't know what their problem is, I send them to someone else. And if that person doesn't know, they send them to someone else. And then this patient is going around to 4, 5, 6, 7 specialists, none of whom are putting their heads together, where we might actually be able to figure it out. But our system doesn't let us do that unless you're in cancer and you have a tumor board. But for everything else, there's no time for that. How would you even get a meeting with all those people, right? And so I think that is another critical thing, at least in the US and the way our system is, that needs to be addressed.
And then they end up in the infectious disease clinic. My last word will be that when we think about putting these teams and advisories together, I think we focus on people that have wellness and are well, but I think we actually need to have people that aren't well to really give that part of the learned experience and lived experiences, really bring people in that are actually still struggling and giving them a safe place to actually help us really understand what's wrong. So we're going to finish up there. I can't thank this panel enough. If you could join me for one last round of applause. It's really a dream team.